Hi everyone, and in this video, we'll be discussing an exciting topic that is ANS pharmacology. Now, what is ANS? It stands for Autonomic Nervous System. So, why should we study this? Let us understand this ANS pharmacology. To understand this ANS pharmacology, we should know the relevance of it. Now, you have you are in your hospital and seeing these patients. A patient comes to the emergency room. His heart rate is 40 beats per minute. We know that the normal heart rate is around 60 to 100. So patient is having a heart rate of 40, it is bradycardia, which is not normal. Second patient has a BP of 80 per 40. So the BP is low. Patient is having hypotension. Next patient is a 32-year-old female. She has wheezing and comes to the emergency room. So why the wheezing occurs? Bronchoconstriction. Now, in all these three patients, let us take the example of first patient. Tell the patient, dear patient, your heart rate is low. Tell your heart to increase the heart rate. Will the heart listen? No. Second patient, tell the patient, dear blood vessels, the BP is low, constrict now. No. The third, so tell the bronchus to constrict. Already they are constricted, now tell them to dilate. Will they listen to us? No. So these systems don't listen to us, and that is what we mean by autonomous nervous system or autonomic nervous system. Autonomous means self-governing. So they will govern themselves. They don't listen to us. Suppose I want to treat these patients and they are not listening to us, then what to do? Then we have to make them listen. How? By giving the drugs. And they are ANS drugs. And that's why we have ANS pharmacologists to study. Now, basically, the nervous system is divided into two important things, the central and peripheral. Central, we have the brain and spinal cord. Peripheral, we have the autonomic nervous system and somatic nervous system. Autonomic, we have the parasympathetic and sympathetic nervous system and enteric nervous system. So, our focus is mainly on the parasympathetic and sympathetic nervous system. So, let us start our journey. Now, before entering this field of ANS pharmacology, I want to give the basics for you first, and then I will go to the drugs. So, with the basics, your understanding and the understanding of the concept will be solid. So, let us start our journey now. ANS stands for autonomic autonomic nervous system. Autonomic nervous system. So, in that we have two systems. One is called the parasympathetic system, and one more is the sympathetic system. Sympathetic system. So let us understand the difference between the two. So let us draw the line and understand the difference. Now, when I think of parasympathetic means when you are relaxed. Now, imagine when you are relaxed, what happens to your body? That is parasympathetic. But imagine that somebody is trying to shoot you, and suddenly a car came to you. So you are terrified. That is sympathetic. Relaxation is parasympathetic. So, parasympathetic is for relaxation, digestion. It is for relaxation, digestion, and also it is for secretion. So, if you want to digest the food, yes, we want secretion. And when you are relaxed, then only you can pass the urine, pass the toilet. So, evacuation. So, it is responsible for evacuation. So, evacuation of bowel as well as bladder. So that is responsible for evacuation of bowel and bladder. Now, what about the sympathetic system? It is activated when you are feared, when you are anger. So it is for the fight, flight, and fright response. And also when it is seen when you are too much anxious. So anxiety can trigger the system. Now it decreases the secretions. It decreases the secretion and decreases the evacuation of bowel and bladder. So that is sympathetic for you. Correct, sir. Okay. Then what about in the eye? In the eye, this causes meiosis and this one causes mydriasis. So meiosis and this is mydriasis. Yes. Now in the heart, what does it do? It decreases the heart rate. It decreases the conduction. In the heart, it decreases the heart rate and conduction. Here, very, very important, it increases the heart rate, increases the conduction. And one more important thing is increase the force of contraction, sympathetic. What about in lung? It causes bronchoconstriction. BC means bronchoconstriction. Here it causes bronchodilation. Bronchodilation. Now, moving on to the other aspects, this is responsible for learning and memory. Remember, parasympathetic means learning and memory. So, if you want to study and you want very good memory, you should be relaxed. Now, another important thing is in the penile tissue, this is responsible for erection and this is responsible for ejaculation. So, remember, parasympathetic is responsible for erection and sympathetic for ejaculation. Now there are receptors involved here. The receptors involved here, they are called as M, that is muscarinic. So we'll write in the future as the capital letter M, and nicotinic. So in the future I'll be writing it as the capital letter N. So these are the receptors. But the receptors in sympathetic are alpha receptor and beta receptor. Another important thing is these systems have neurotransmitter. NT stands for neurotransmitter and that is acetylcholine for here. The neurotransmitter is acetylcholine. In the future I'll write it as ACH. Here the neurotransmitter is called let me repeat that, it is called noradrenaline. It is called noradrenaline. In the future I'll write it as NA. So noradrenaline or NA. Now again, if I just continue the differences, this output is from mainly the craniosacral outflow. So cranial nerves, what are the cranial nerves which will give rise to that? That is 3, 7, 9, 10. 10th is vagus nerve. Sacral are S2, S3 and S4. So this is thoracolumbar. Thoracolumbar. So guys, this is the basics you need to keep in your mind before I start the drugs. So parasympathetic and sympathetic, remember, when you're relaxed, digestion, secretions, erection, decrease in heart rate, bronchoconstriction, these are parasympathetic. Opposite is sympathetic, that's it. The major neurotransmitter in parasympathetic is acetylcholine. Here it is noradrenaline. The receptors in parasympathetic is muscarinic and nicotinic. Sympathetic is alpha and beta. The parasympathetic is craniosacral outflow and the sympathetic is thoracolumbar outflow. So that's the basics for you. Okay, sir. We understood the basics, correct. Now once I understand the basics, how do they function? How will the drugs work? To understand that, let me draw the system now. This is the brain and this is the spinal cord. I'm just taking the example. Okay, the brain and spinal cord. Now we told you the parasympathetic is from the cranial nerves. Let me take the example here. So the nerve will come. Now the nerve, when it comes, it forms a synapse. So it forms a synapse and then from there it will get one more connection. Now where it forms the synapse, the nerve making a synapse with another nerve, we call it as ganglia. So this is called ganglia. And the fibers what I wrote is the parasympathetic fibers. But anything, the nerve has to communicate, there should be release of a neurotransmitter. That is the one which carries the message. Here the neurotransmitter is called acetylcholine. So in this ganglia, the neurotransmitter is acetylcholine. Now once the signal is coming, this acetylcholine is released at the junction where the nerves are going. and meeting the target organs. So let me write the target organ here as heart. So this is the heart. Let me write that. I am taking one example, one organ, how the sympathetic parasympathetic control that. So when the parasympathetic gets activated, the acetylcholine gets released. Now this is a neurotransmitter at the target organ. So the receptors at the heart are called M2 receptor. When they are activated, what happens to the heart rate? The heart rate comes down. The heart rate comes down. Clear, sir? We are clear with that. Fine. Now let me write one more system. The system is sympathetic. Now in sympathetic system, this is the ganglia. Now what is the difference here? The sympathetic system, the ganglia are closer to the spinal cord. So presynaptic fibers are shorter, but the postsynaptic fibers are longer. Let me write here. So this is what we mean by the sympathetic ganglia. Sir, what is the neurotransmitter there? Remember, any ganglia you take, the neurotransmitter is acetylcholine. Whether you take the example of sympathetic fibers or parasympathetic, even though they are sympathetic fibers, sympathetic ganglia also the neurotransmitter is acetylcholine. But when they come to the target organ here, the neurotransmitter that is released is noradrenaline. Here it is noradrenaline, and noradrenaline acts on the receptor called beta 1 in the heart, and that will increase the heart rate. So this is how they are in balance. So our heart is normally beating because 60 to 100 beats per minute, because the parasympathetic is trying to decrease the heart rate, sympathetic is trying to increase the heart rate. They are in balance. So that's why the heart rate is normal. But if it is an emergency, you want to run a race, 100-meter race, you want to run, then sympathetic takes over, the heart rate increases. When you relax, heart rate decreases. That's what, if you make more and more stress, the heart rate increases. Okay, sir, we understood that. Now, you can see the neurotransmitter here is noradrenaline. But there are certain exceptions for this. Sympathetic has exception. Where, sir? Sympathetic has an exception, that is, even the fibers are sympathetic. Certain places there are cholinergics. For example, in the sweat glands, the neurotransmitter is acetylcholine. It acts on the receptor called M3, and it acts on a sweat gland called thermoregulatory sweat glands. Thermoregulatory sweat glands. So there, even the origin is sympathetic, but they are called as sympathetic cholinergic fibers. This is exception. In thermoregulatory sweat glands, even though they are sympathetic in origin, but the neurotransmitter is acetylcholine, an exception, you all know it, very good. Second important exception is another, that is called dopamine. The dopamine acts on the receptor called D1, and that is mainly present in renal blood vessels. Renal blood vessel. So this is an exception. Everywhere in sympathetic it's noradrenaline, but exception is thermoregulatory sweat glands and renal blood vessel. I will ask you one more general physiology and anatomy here. Most of you know the adrenal medulla. So let me write the adrenal medulla here. This is the adrenal medulla. Now you all know that adrenal medulla is a modified ganglia. Now you tell me, this site, the site A, what I am writing here is a site A. What is the neurotransmitter released here? Yes. What is released in B from the adrenal medulla? Take a guess. So any ganglia, the site A, I told you it's a modified ganglia, it is acetylcholine. So here, adrenal medulla, the neurotransmitter is acetylcholine, and when you stimulate adrenal medulla, the release is the catecholamines, that is adrenaline and noradrenaline are released. Very, very important, valid point for you. Okay, sir, we understood the general, but where is pharma here? Where is pharma, sir? Okay, let me tell you. Now, when I started this video, I told you there is a patient with heart rate of 40 beats per minute. Now, how do I increase the heart rate of this patient? Now, we have drugs. If I give the drug called isoprenaline, there is a sympathetic drug called isoprene. What happens? It stimulates beta 1. So it makes the beta 1 activity more. I told you they're in balance. What you do? Increase the activity of beta 1. So what happens? The heart rate goes up. So isoprene increases heart rate. So you can do one thing, stimulate the beta 1. So stimulate the beta 1. Yes, you can do like that. Now, one way I told you like this. Second way, if they're in balance, can we do something else? Yes, think and tell me. Now what I can do is, I can block M2. Now when they're in balance, if I block the M2, the parasympathetic activity will not there, the sympathetic will automatically go up. So another way is blocking that. So the drug that blocks that receptor, muscarinic receptor, is atropine. Now if I block M2, who will take over? Sympathetic will take over, and there is increase in heart rate. So atropine also increases heart rate. Very good. So we have two important ways to do this job. Either stimulate sympathetic or block the parasympathetic. So like that, in every system, we have this. The agonist, that is called stimulator. The blockers, also called as antagonists, can be used. So like that, we have plenty of drugs in ANS pharmacology. This is just an example. Okay. So in this patient, what we started our case with, we can either use atropine or we can use isoprene to increase the heart rate. So this is how we alter this. I told you, if they don't listen to us, we will make them listen by giving the drug. Sir, once we understand this, let me take one more example. You all know it. It's a simple basics. This is the bronchus. This is a bronchus. Now bronchus has a receptor called beta 2. Now beta 2 is stimulated by the sympathetic system and it causes bronchodilation. Sympathetic system stimulates the beta 2 and bronchodilation. We have the parasympathetic system which activates M3, muscarinic receptor, and cause bronchoconstriction. Now, you know the third patient. What is the third patient? The third patient is wheezing. Now, what should I do? Which one should I stimulate? Which one should I block? Tell me that. Yes, I should stimulate beta 2. So the drug which stimulates beta 2, we have a drug by the name salbutamol. So for the third patient, I can give a drug by the name salbutamol. Or I can block M3. What happens if I block M3? Who will take over? Beta 2 will take over. So the drug is called ipratropium. So this is how we have plenty of drugs in ANS pharmacology. So what you desire, you will get it. So we'll understand that in the next few slides. Okay. So once we understood the basics, let us start with the system wise. First of all, let me introduce the parasympathetic system. Parasympathetic system. Now, parasympathetic system is also called as another name, and that is called the cholinergic system. Sir, why it is called cholinergic system? The reason is simple, because a neurotransmitter is acetylcholine. That's why the name cholinergic system, because everywhere it is acetylcholine. Let me recap this. In parasympathetic system, everywhere you see acetylcholine as a neurotransmitter, but sympathetic, there is some difference. Mainly it is norelin, but there are exceptions. Where are the exceptions? Ganglia, adrenal medulla, thermoregulatory sweat gland, it is acetylcholine, and renal blood vessel, it is dopamine. So these are the exceptions. Now, moving on to this, first of all, we need to understand the receptors. So parasympathetic has receptors. Two important receptors what we have here is the muscarinic receptor, that is M, and the N receptor, that is nicotine receptor. Now the muscarinic receptor are called as G protein coupled receptor, and nicotine receptors are ion channel receptor. Now let us correlate general pharma. Tell me which one is faster acting, ion channel receptor or GPCR? Yes, obviously ion channel receptor. So Here, that's why the nature has kept the ion channel receptor in the fast conductive fiber, for example, NN junction. So NN stands for nerve-nerve junction, and that is present in any ganglia in our body. So ganglia, what I showed you, there it is present. And what is a modified ganglia? I told you that it is called adrenal medulla. So there the neurotransmitter is acetylcholine, the receptor is NN. One more important place is NM. NM is neuromuscular junction. So it is present in neuromuscular junction. Sir, you told these are ANS, but what about the skeletal muscle? You know that skeletal muscles are under our control. So there also the neurotransmitter is acetylcholine and the receptor is NM receptor. Here it is NN receptor, and they are ion channel receptor. They are the fastest acting. So coming to the muscarinic receptor, what is it, sir? Muscarinic receptor has M1, M2, M3, M4, M5. There are 5 important receptors, sir. But remember, mainly we need to understand 1, 2 and 3. But M2 as well as M4, they are GI coupled receptor. So they are inhibitory in nature. And simply you can remember they are the even numbers. Second, the M1, M3 and M5, they are GQ coupled receptor. They are called GQ coupled receptor, and remember they are all the odd numbers. So simple to remember. But what should I remember for the exam? I told you mainly remember the 3 important ones. So what are those? Let me write here. What are those? In that, the M1. Now the major location of M1 is in the CNS, central nervous system, and it is also present in the gastric gland, that is parietal cells. Gastric glands. Then we have another receptor called M2, which is GI coupled receptor. M2 is mainly present in the heart. It is mainly present in the heart. Where is M3, sir? M3 is present in S for smooth muscles. You take any smooth muscle like the intestine, the bladder, everywhere it is M3. And remember in the eye, 2 important muscles in the eye, let me tell you. One is called the sphincter pupillae. Sphincter pupillae. So it will cause miosis, and also it is present in ciliary muscle. So in ciliary muscle, it will cause the spasm of ciliary muscles. And remember it is present in exocrine gland. So exocrine gland, I told you parasympathetic means secretions. You take the lacrimation, salivation, sweating, intestine secretions are increased, bronchial secretions are increased. So these increased secretions. So parasympathetic means, remember, secretions. So this is the location of M1, M2, M3. Let me repeat, M1 in CNS and gastric gland, M2 in the heart, M3 in smooth muscle, eye and exocrine gland. M4, M5 are also present in CNS but not that much important for it. Yes. Now once I know the location of receptor, it's important to understand how the message is communicated. I told you the parasympathetic is communicating from the cranial nerve and sacral, that is S2, S3, S4. But how the communication occurs? Let me tell you that. Suppose this is a nerve. This is a nerve. And it has to communicate with another nerve. It has to give a message, either to stimulate the heart or decrease the heart rate or whatever. So for that, there is a release of a neurotransmitter. So there is a release of neurotransmitter, and this terminal is called the presynaptic terminal. And the junction between 2 nerves is what we mean by synapse. So whenever the action potential comes, the sodium enters along with the calcium enters, and then the neurotransmitter is released. So the neurotransmitter will act on the receptors present in the, what is the junction called, post synaptic terminal. So the receptor will be stimulated, and after this, the action of neurotransmitter is terminated. The action is terminated. So this is what we mean by the neurotransmission. So what we mean by this is neurotransmission. Neurotransmission. Okay, so simple. If there are two nerves, let me tell you like this. There are two nerves like this, and this nerve want to communicate with this nerve. So this nerve will release the neurotransmitter. It will come, stimulate the postsynaptic terminal, and the neurotransmitter gets terminated. So neurotransmitter is like a messenger. I can give an example like a postman. A postman will give you a letter, and after that he will go home. He will not stay in your home. So the action has to be terminated immediately. So the junction is presynaptic. The junction is synaptic, and this is presynaptic neuron. This is postsynaptic neuron, and the transmission is called neurotransmission. So what I will do is I will expand this, and I will understand. We will try to understand what are the drugs acting on this. Let's start our journey. So let me write the synapse here. So until now we have understood what is neurotransmission, and let us understand what exactly happens in neurotransmission and what are the drugs going to affect that. Let me write that. So this is the presynaptic terminal. This is the presynaptic terminal, and this is the postsynaptic terminal. So this is the presynaptic terminal and postsynaptic terminal. Let us understand what happens here. So we have the acetyl-CoA. So acetyl-CoA combines with choline. It combines with choline to form the neurotransmitter acetylcholine. So that is formed. Now this is formed, and it has to be stored in the vesicle for future use. So it will be stored inside a vesicle. So it is stored in the vesicle with the help of vesicular transporter. So that is the one which will put it inside. The name is called vesicular transporter. So acetylcholine is synthesized, it is stored in the vesicle. Now what happens whenever the signal comes? Whenever the signal comes, the sodium enters inside. Along with sodium, the calcium enters into the presynaptic terminal. Now when that enters, this calcium will give a command to release acetylcholine. So the synapse, that is presynaptic terminal and vesicle, they fuse, and when they fuse, they start releasing acetylcholine. So there is release of acetylcholine. So when the calcium comes inside, then the vesicle will fuse with the presynaptic membrane, and there is release of acetylcholine. Now this acetylcholine acts on the receptors like nicotinic, muscarinic, depending on the target organ. Now I told you the messenger should not stay there for a very long period, and that is terminated with the help of an enzyme, and that enzyme name is called, let me write, it is called as choline esterase. So it is called as choline esterase or acetylcholine esterase. That is the enzyme which will break it down. So when it breaks down, we get two important things. One is called acetate and choline. So we get the acetate plus choline. So we get this. Now what happens again? This choline will again go back from where it came. So this is where it goes back. So it goes back again into the place where it has come. Along with sodium, choline also moves inside, and we call it as the choline uptake. So we call it as the choline uptake. Right. So this is the understanding. This is a normal physiology what you need to understand. So acetyl-CoA combines with choline to form acetylcholine, and that is stored in the vesicle with the help of vesicular transporter. The action potential comes from the presynaptic terminal. So sodium enters, calcium enters. Then the vesicle will fuse with the presynaptic membrane. Acetylcholine released, acts on the receptor. It is terminated by the enzyme choline esterase, and again you get choline So choline uptake is the rate limiting step. Rate limiting step here is choline uptake. Sir, can we block these steps? Yes. The first step, that is choline uptake, is blocked by a drug. So the inhibitor is called hemicolinium. It is called hemicolinium. You read the name. The name has choline itself. So it inhibits the choline uptake. That is number one. Number two, you can also inhibit the vesicular transporter. The inhibitor of vesicular transporter is called vesamicol. So the name is called vesamicol. The name is vesamicol. We'll know the name because it starts with vesicle. Vesamicol inhibits vesicular transporter. Hemicolinium, I for inhibits what? Choline uptake. Now the third important thing is you can inhibit the enzyme cholinesterase. Now these drugs which inhibit that, they are called anti-cholinesterases. So the drugs are called as anti-cholinesterase. I'll give an example. Now if you take the example of acetylcholine, we know that acetylcholine directly stimulates the receptors M and N. Now we can call acetylcholine as a direct cholinergic drug. Acetylcholine is called as direct cholinergic drug. The reason is simple, it will directly stimulate the receptor. So the direct meaning is they directly stimulate the receptor, that's it. Now if I use a drug which inhibits the enzyme cholinesterase, they are called anticholinesterase. Now what happens when you inhibit the enzyme? Can you tell me? When you inhibit the enzyme, the acetylcholine is not broken down. That means its level goes up and that will act on the receptors M and N. So that will act on the receptor M and N. Now these drugs which inhibit this, are they going to directly stimulate the receptor? No. They are inhibiting the enzyme. Acetylcholine increases, that will work. So that's why these are also called as indirect cholinergics. These are also called as indirect cholinergics. So in the future, I will be asking you what is indirect cholinergic. You have to tell me they are anti-cholinesterase. What do you mean by indirect? They don't directly act on the receptor. Okay, that is the meaning of it. So we understood that this is the third target, right? Now the number 4 important target is, now there is a toxin. The toxin will not allow the release of acetylcholine. So it will act here. Let me highlight it. The acetylcholine release, this is inhibited by a toxin. One of the deadliest toxin to the human beings, it is the botulinum toxin. Botulinum toxin, they have asked plenty of times the mechanism of action. It decreases the acetylcholine release. It decreases the acetylcholine release. So please mark it. This is one of the commonly asked question in exam. Very much important. Now when I am talking about botulinum toxin, it's important that I tell you the importance of it. So basically, when you know this, please understand this is a neurotransmission and you need to understand hemicolinium, vesamicol, what is anticholinesterase and what is the role of botulinum toxin. These are the major thing you need to understand. So what is the mechanism of action of botulinum toxin? Is to decrease the acetylcholine release. Okay. So the next slide what I am going to discuss will be about the botulinum toxin. Botulinum toxin. Now let me write the same junction here. This is the nerve and the muscle. Let me write the muscle. This is the muscle. So this is the neuromuscular junction. So this is the skeletal muscle. This is the skeletal. This is the skeletal muscle. Now what happens? We know that acetylcholine is stored in the vesicle and it's released. It fuses and acetylcholine releases. There is a receptor called NM and that is responsible for the contraction of skeletal muscle. Now what happens if I use a botulinum toxin? The botulinum toxin will not allow the release of acetylcholine. So it inhibits it. Now what happens if I use botulinum toxin? muscle will contract or relax. So this will lead to skeletal muscle relaxation. Okay, sir, let it cause skeletal muscle relaxation. What is the problem? Problem is if I give this IV, what happens? It will relax all the muscles of your body. The main muscle diaphragm, the respiratory muscles, if they get paralyzed, patient will die because they cannot breathe because the muscle is paralyzed. Why the muscle is paralyzed? Because the acetylcholine is not getting released. That's why I told you it's one of the deadliest toxin known. Now one more toxin I will tell you which can block the NM receptor in the muscle. So there is NM receptor in the muscle that is blocked by a toxin called cobra toxin. So when there is cobra bite, patient will have the neurotoxicity, that is there is muscle relaxation. So that's why in cobra bite along with anti-snake venom, we use certain drugs called neostigmine or pridostigmine. I will tell you what is that. So they will overcome this neuromuscular blockade. So botulinum toxin is very important. Then why are we discussing that, sir, if it is toxic? The reason is it is used locally. Botulinum toxin is used locally. Botulinum toxin is used locally for certain cosmetic reasons. And remember, never use it systemically. What are the uses of this? Now, if I give locally, suppose I have wrinkles on my forehead, if I inject it locally, what happens? The muscles will relax locally. I'm not giving it systemically. So that's why it is used for cosmetic purpose. And most of you heard of the injection Botox. Botox is nothing but botulinum toxin. Sir, where did we get this toxin from? Clostridium botulinum, a bacteria. So cosmetically, it's very important. It is used to treat two important conditions: the glabellar lines, wrinkles. Second important, it is used in the muscle spasm like strabismus, and the eyelid spasm called blepharospasm. So remember, all these places we are using it locally. Or cervical muscle spasm, the neck spasm, we call it as cervical muscle spasms, and a condition called achalasia cardia. Achalasia cardia. So here the acetylcholine tone is very high on the esophagus, and decreasing that tone will help in achalasia cardia. So acetylcholine release is decreased, and remember, every places what we have written the uses, it is used locally. Now this toxin has various subtypes A, B, C, D, E, F, G, S, like that. But in that, the most important subtype is toxin A, and we call it as ona botulinum toxin A. So you already know botulinum toxin. I have added ona for this, toxin A for this. That's it. Now this is approved for certain special purpose. What are those? Number one, it is used locally for migraine prophylaxis. Migraine prophylaxis. And one more bladder condition. What is it? What is it? It is called as overactive bladder. Overactive bladder. Very good. So this is about botulinum toxin. Most common question in exam is what is the mechanism? It decreases acetylcholine release. So let us understand the concept here. Concepts. Now what we do is we go from head to toe, from CNS, eye, mouth, like that. And what we do is we'll write what is the physiological function, and that will take us into uses or adverse effect. Let me give an example. Let me start with the first system. The first system is the CNS. Now what happens if you are relaxed? Imagine that you are relaxed now. What happens? There is increase in learning, there is increase in memory. So this parasympathetic can increase the learning and memory. Can you tell me where we can take the advantage? Which disease we want to increase the memory of a person? Yes, you are talking about Alzheimer's disease. Yes, you are correct. So I can use it in Alzheimer's disease. So these drugs are used in Alzheimer's disease. Now, any adverse effect with that? Now, learning and memory is not an adverse effect. Everybody wants it. Now you are studying for exam, you also require that. Yes. Now moving on to the next system. The next system is the eye. Now what happens in the eye? Eye has two important muscles. One is called the sphincter pupillae. The sphincter pupillae. Now when you activate this, patient will have miotic effect. So it will cause miosis. Second muscle in the eye is called the ciliary muscle. So ciliary muscle, if you stimulate this, it causes the ciliary muscle spasm. So it will cause ciliary muscle spasm. Now, when there is ciliary muscle spasm, we call it as spasm of accommodation. Spasm of accommodation. Sir, what do you mean by spasm of accommodation? Spasm of accommodation means person can see the near object clearly. So here you can see clearly, but a far object is blurred. You know the accommodation reflex. Suddenly you are seeing far and you want to see the near object, the lens will adapt to that. But in spasm of accommodation, you are looking here, the lens will be normal, you can see that. But when you look far, you will have blurring option. That is called spasm of accommodation. Okay, sir, that is fine. Sir, tell me which receptor is present in the eye. I told you in the eye it is M3 type of receptor and in CNS it is M1 type of receptor. Correct. Now, why do you take the advantage of miosis, sir? Where do you want to constrict the pupil? Number one, when you are managing glaucoma. When you are managing glaucoma. Second, suppose already there is mydriasis. A drug has been given, mydriasis is already there. You want to counteract that, then we can use it to counteract mydriasis. To counteract mydriasis. Correct. Sir, what is the adverse effect if you do miosis and spasm accommodation? Patient will have the eyebrow pain. The adverse effect is eyebrow pain. That means if you constrict the pupil for very long period, patient will have the eyebrow pain. The brows will become painful. So this is how we learn the things. So you understood the eye. Now once you understand the eye, the third important aspect I need to understand and teach you is mouth. And mouth is having salivary glands. So mouth is having salivary gland and also there is lacrimal gland that is in the eyes. So it increases lacrimation that is in the eye and in the mouth it increases salivation. Now you tell me which condition you want to increase lacrimation, increase salivation in a person. Think and tell me which condition you want to do it. Is there a condition where there is dryness of mouth, dryness of eyes? Yes, the syndrome is called Sjogren's. So we use it in a condition called the Sjogren syndrome. Okay, if I give it in a patient with Sjogren syndrome, that will be fine. But if a patient doesn't have this problem, if I give this parasympathetic drugs, what happens? He will be lacrimating, he will be salivating. So these drugs adverse effect will be increase in lacrimation and increase in salivation. So I am writing like this, guys. So the column you can understand the action, the uses and adverse effect. Yes, fine, sir, fine. Now let us move on to the next organ. What is the fourth one? Fourth important is heart. So what is the receptor present in the heart? Remember it is mainly the M2 receptor. Heart it is M2. Heart there is speciality. Now heart has the atria and the ventricle. Now in the atria, it decreases the heart rate, it decreases the conduction and decreases the force of contraction. But in ventricle, it only decreases heart rate and decrease the conduction in ventricle, but it doesn't affect force of contraction. Why, sir? Why? Now, the ventricles are mainly innervated by sympathetic fibers, very minimal parasympathetic. That's why the force of contraction is not affected much. So, in atria, you can see the decrease in force of contraction, but in ventricle, you will see only decrease in heart rate and conduction. Now, tell me which condition you want to decrease the heart rate. Yes, obviously, we want to decrease the heart rate in a condition called tachycardia. If the heart rate is more, then suppose a patient doesn't have tachycardia, if I give these drugs, what is the adverse effect? Obviously, patient will have bradycardia, the heart rate decreases, and there is decrease in conduction. So AV block. So there is decrease in conduction. Correct, sir. Okay. Now, whenever I talk about the heart, one more organ we need to discuss is the blood vessels. So the blood vessel. So let me write the blood vessel for you. This is the blood vessel. This is the blood vessel. Now, blood vessels, they are innervated. So this is the nerve. Now they are only innervated by sympathetic fibers. They are only innervated by sympathetic fibers. Parasympathetic fibers are not innervated. Suppose if I stimulate these fibers, the norlin comes to the picture, it acts on the receptor and you see vasodilation or constriction depending on the receptor, we'll discuss that. But this type of facility is not there with the parasympathetic. So that's the reason parasympathetic doesn't govern the BP much. So if you want to increase the BP, you have to stimulate the sympathetic. If you want to decrease the BP, you have to block the sympathetic. That's it. Parasympathetic doesn't have a role in that. So sympathetic are the one who have taken care of our blood vessels and BP. Please keep that in mind. Sir, if I give acetylcholine IV, what happens? If I give acetylcholine intravenous, the acetylcholine enters inside and there are cells in the endothelium and these cells have a receptor called M3. Now when you activate that M3, they release something called nitric oxide and that is going to cause vasodilation, sir. Vasodilation, sir. You may ask a question, sir, why can't we use acetylcholine? If it causes vasodilation, obviously when you cause vasodilation, there is decrease in BP. Now we are not using acetylcholine for therapy because when we give acetylcholine, it is very short acting. Now when I give acetylcholine intravenous, in the blood vessel there is an enzyme called pseudocholinesterase. The enzyme name is pseudocholinesterase. So it has one more name and that is called butyryl cholinesterase. So this is an enzyme which is present in our plasma. Now when I give acetylcholine, it is hydrolyzed by this enzyme. It is hydrolyzed by this enzyme. Sir, what is the difference between the cholinesterase which was present in the synapse? So I told you there is a cholinesterase in the synapse. Let me write here. This is the junction between the nerve. So when the acetylcholine is reached here, it is metabolized by the true cholinesterase. These are called true. Now they are going to work in the synapse, but when we give acetylcholine IV, it is metabolized by the false, that is pseudocholinesterase, or it is also called as butyryl cholinesterase. Now here the cholinesterase will metabolize it faster, but here it is slower. Again, when I give acetylcholine IV, it is very short acting because it is fast metabolized. So it is not used for therapy. Okay. So any drug, I will give one more important clue for you. Any drug metabolized by these pseudocholinesterase are usually shorter acting. So in the future, we'll be discussing those drugs. I'll give an introduction like succinylcholine, mivacurium, remifentanil. These are metabolized by these esterases in the plasma and they are very short acting. Okay. So blood vessel, that's it. Because blood vessel is mainly controlled by sympathetic. Moving on to the fifth one, lungs. So what is the action in the lung? It causes bronchoconstriction. Not only that, it increases the secretions in the lungs. Any other use of that Should we constrict somebody's bronchus? No. So there is no use of that. So what is the adverse effect patient will have? Bronchoconstriction and increase in secretions in the lungs. So there is increase in secretion, that is the adverse effect. So no use of that in the lungs. Sixth one. Sixth one is stomach. And let me also tell you the receptor in lung is mainly M3 receptor. What about stomach? Stomach has parietal cell and parietal cells is M1 receptor. I told you when you start eating the food, the salivation increases and then the gastric acid secretion increases. So obviously parasympathetic increases salivation, then ALE secretions. So it increases the gastric secretions. So predominantly it increases the secretion of HCl. So what happens if HCl is increased? Nobody wants to increase HCl secretion, which will cause gastritis. So the adverse effect for the patient will be gastritis. The patient will have gastritis with that. Now moving on to the seventh important system is the intestine. Intestine. So intestine are mainly by M3 receptor. Now please imagine this. If you have run 100-meter race and you go to the toilet, will you be able to pass the toilet? No. When you are relaxed, then only the intestine will move, the sphincter will open. So intestine, they increase the motility of smooth muscles and they open the sphincter. Now, where do you want to increase the motility of the small intestine or large intestine and open the sphincter? Obviously, in the management of constipation. So in the management of constipation, we can use it. But there is one more condition called post-operative paralytic illness. So what is that? What is that? Now what happens during surgery? We give anesthesia. When you give anesthesia, what happens? Anesthetic agents will all decrease the motility. They decrease the motility of bladder, intestine. Now once the patient is shifted from the OT to post-op ward, he has to be started on fluids. How do you decide to give the fluids? Depending on whether the motility has started or not. So we either use the stethoscope to check the bowel sound, or we ask the patient whether he has passed whether he has passed the gas. Now, if the patient is not getting any signs and symptoms of that motility, then we have to give the drugs. So that is called post-operative paralytic ileus. So we use it in post-op paralytic ileus. Post-op paralytic ileus. Okay, sir, we got it. Fine. Now, what is the problem? If I give it to a normal person, patient will have the adverse effect diarrhea. So the parasympathetic system can cause adverse effect diarrhea, but we can take the advantage of it. Okay, sir. Okay. Then next, eighth, the bladder. So we are talking about the urinary bladder. The urinary bladder. Again, the receptor is same M3. So we have the detrusor and the sphincter, urethral sphincter. So it increases detrusor contraction and open the sphincter. Open the sphincter. Now tell me, where do you want to do this? Increase the motility of bladder, open the sphincter. Where do you use it? Same thing, post-operatively also we will have a problem called post-op urine retention. So whenever the urine is retained, or the bladder is not evacuating properly, so we call it as atonic bladder. The tone of the bladder is less, so there we can use it, atonic bladder. I told you post-operatively the motility of the bladder or the intestine can decrease, that is called the post-operative complication. Now if I give the drugs to the normal individual, it can increase the urination. So that is the adverse effect of the parasympathetic system, that can increase the urination. Now what about the next system, the ninth one? In the penis, it is known to produce erection. So until now we are not successful in getting any drug so that it causes erection. Particularly, I'm talking about parasympathetic. We have other drugs for that erectile problem, sildenafil and all those things, but as such, parasympathetic drugs are not available till now. Then talking about the last one, it's not a autonomic, it's a skeletal muscle. It's a skeletal muscle. What happens in skeletal muscle? Skeletal muscle. Why I'm talking? Because we have acetylcholine there. That's why I'm talking here. Now let me write the same junction which we have discussed already. So this is the junction. This is the muscle. Now here the acetylcholine gets released, and this is the skeletal muscle, and it acts on the receptor called the NM receptor. And we know that this will cause the muscle contraction. MC stands for the skeletal muscle contraction. Now, why should we use the drugs which increase the activity of acetylcholine in NM junction? Now, there are certain diseases which affect the NM. So, there are certain diseases which affect the NM junction. There are drugs which can block NM receptors. They are called as non-depolarizing skeletal muscle relaxant. SKMR stands for non-depolarizing skeletal muscle relaxant. Example is D-tubocurarine. So what we do is, when we are putting a patient in surgery, we have to give anesthesia. When we give anesthesia, we also have to relax the muscle. So what we do is, we use the drug called D-tuberculin. Not only that, we have other drugs like pancuronium, then vicuronium, like that. So when we have given the muscle relaxant, we'll block the NM receptor and the muscle is relaxed. But if you want to reverse it, then we have to use the drugs. The drug should increase the acetylcholine. So when they increase the acetylcholine, then you can overcome the block. So there we use these drugs which are going to increase the acetylcholine. Second, there is a problem for NM receptor. There are autoantibodies. The autoantibodies are produced in a disease called myasthenia gravis. Myasthenia gravis. And one more problem is NM gets blocked. Where? Which toxin NM is blocked? I told you is cobra toxin. So in all these conditions, you have to increase the activity of acetylcholine. That is, when you want to reverse the non-depolarized skeletal muscle relaxant, when you want to treat myasthenia gravis, when you want to treat cobra bite, in all these conditions, you have to overcome by increasing acetylcholine. So you have to increase the acetylcholine, but how do you increase the acetylcholine? How? Because acetylcholine is metabolized by the enzyme cholinesterase. If I inhibit that, they will increase the acetylcholine and we can use them to treat this. Okay, we'll come to that point later. Please understand the concept here. So in managing these conditions, we have to increase the acetylcholine. How do we do that? By inhibiting the enzyme cholinesterase. What are the name? They are called as anticholinesterase. So we can use them. Okay, the next problem here is, what if I stimulate the receptor repeatedly? Suppose there is acetylcholine is excess, and if I keep on stimulating the receptor again and again. So if you stimulate the receptor again and again, these NM receptors are going to cause rapid desensitization. So if you stimulate NM receptor repeatedly, the receptors are undergoing rapid desensitization. That means they don't work. Desensitization means receptor won't work, so the muscle will relax. So that is called the flaccid paralysis. So where do you see this acetylcholine excess? There is a poisoning called OP poisoning, where we see acetylcholine excess and the patient muscle will get paralyzed because excess of acetylcholine keep on stimulating NM and the rapid desensitization occurs and muscle paralysis occurs and the respiratory muscle paralysis occur and patient may die because of organophosphate poisoning. We'll come to that later, don't worry. This is just an introduction for you. Clear? Yeah, that is about skeletal muscle. Now, the adverse effect is, if acetylcholine is excess, muscle paralysis, but these are the uses to increase acetylcholine. Okay, clear with that? Now, I want you all to just pause the video and try to analyze the system in a CNS, eye, mouth, heart, lungs, intestine, stomach, like that. Just do that. Okay. So let me revise it again. CNS, it increases learning and memory. We can use it in Alzheimer's disease. I, it causes meiosis and spasm of accommodation. We can use it in glaucoma. And also to counteract mydriasis, the problem is the brow pain, that is eyebrow pain. It increases salivation and lacrimation. So where can we use it? Zongrad syndrome. If I give it to a normal person, he will have more salivation, more lacrimation. Heart, it decreases the heart rate, conduction, contraction in atria. In ventricle, it only decreases heart rate and conduction. It doesn't affect the force of contraction. Which condition you want to use it? Tachycardia. What is the adverse effect? Bradycardia and heart block. Lungs, it causes bronchoconstriction, increases secretions. Then coming to the stomach, what does it do? Increases HCl secretion, patient gets adverse effect gastritis. Then intestine, it increases the motility and opens the sphincter. We can use it in constipation or post-operative paralytic ileus. The adverse effect is diarrhea. Bladder, it increases the evacuation of bladder. We can use it in post-operative urinary retention or atonic bladder. Adverse effect is urination. Yes. Then in the penile, it will increase the erection. Skeletal muscle, it is required for contraction, but if you stimulate excessively, it will cause flaccid paralysis. But we can take the advantage to increase the muscle contraction in certain conditions like myasthenia gravis. Then to reverse the muscle relaxation like D-tuberculin, and one more in cobra bite. So I can summarize this adverse effect with the mnemonic. So the adverse effect can be remembered by the mnemonic dumbbells. So dumbbell stands for diarrhea. You can see the list. Is it there? Urination, yes. Meiosis, yes. Bronchoconstriction, yes. Bradycardia, yes. It can also cause emesis. Now, there is a vestibular apparatus in the ears and they are mainly having M1 receptor. Now, these can get activated in something called motion sickness. What is motion sickness? When you are going in a giant whale or when you are going in a hilly area, the vestibular apparatus gets activated in some people. They start vomiting and that is triggered by the activation of M1. Then L for lacrimation and L for more secretions. So what are the secretions? Salivation, sweating. So all these secretions and increase in lung secretions. All these are the adverse effect when you stimulate the receptors. But if you stimulate the receptor NM repeatedly, so repeatedly stimulation, what happens initially is fasciculation, and then the receptor will undergo desensitization. Receptor will undergo desensitization, and later you will see the flaccid paralysis. So this is what we see in a poisoning called organophosphate poisoning. We'll discuss that. So the excessive action of acetylcholine on muscarinic receptor you can see here. The excessive action of acetylcholine on nicotinic receptor you can see here. So when this is excessive, this is the adverse effect what we see. Okay, right now we are in a position to understand the concept better. Now once I understand the concept in a better manner, it's important that I understand the drugs now. Let us start our journey. So we have the drugs in choline system. They are called cholinergic drugs. In cholinergic drugs, I can classify them into two important types. One is the direct and indirect. Direct cholinergics and one more is called indirect cholinergics. Yes, so you know the simple meaning. Direct cholinergics are nothing but which directly stimulate the receptor M and M. Indirect are the one which doesn't directly act. They act by inhibiting the enzyme cholinesterase. So they're also called by another name anti-cholinesterases. Don't confuse with anticholinergic, that's a different one. Now, in direct cholinergics, we have two important ones, the choline esters. So, we have the choline esters and then plant alkaloids. Plant alkaloids. So, plant alkaloids are nothing but what we get naturally from the plant. Example is RA choline. RA choline is nothing but it is present in the betel nut, what people chew. So, why do they chew after the meal? To increase the salivation. Then we have muscarine. Okay, let me start from here. After RA choline, we have one more thing that is called muscarine, and then one more thing called pilocarpine. Now, all these are derived from plants. In all these three, the only thing what we are using in therapy is pilocarpine. Pilocarpine is used in two conditions. What are those? It is used as eye drop. Now, eye drop, it is used as a meiotic. So, the meiosis caused by this is called active meiosis. So, it causes active meiosis and it is used in glaucoma. It is used in glaucoma. The drug is called pilocarpine. Now, it is also given as oral drug. The oral drug is given for Sjogren syndrome, to manage Sjogren syndrome. That is pilocarpine for you. Okay. Now, aracholine and muscarine are not used therapeutically. Aracholine and muscarine are not used therapeutically. Coming to the choline esters, in choline esters, the first drug what I am going to discuss is by the name acetylcholine. Now, acetylcholine is not used therapeutically. Why, sir? Why can't we give it? Number one, it's very short acting. I told you if I give that IV, it is metabolized by pseudocholinesterase and the action will get over within 5 to 10 minutes. So that's the reason it has to be used only for experimental purpose. The number one reason is it's very short acting. The second reason is it's not specific. That means it will act on M1, M2, M3, M4, M5, NN, NM, everywhere. Now, what is the problem if it acts everywhere? If the drug is non-specific, obviously the adverse effect increases. We have written the dumbbells, muscle paralysis, all those things. So, it is non-specific to receptors. It has non-specific actions on the receptor. So, that's the reason. Then third, it is used for experimental purpose only. Experiments only. So, in the medical colleges, in some of the research institute, they are used to check the effect of acetylcholine on various organs. So, then we came with another choline ester that is called methacholine. Now, methacholine story is it is mainly effective for M2 more than M1. M2 more than M1. Now, it is used for managing tachycardia. Now, I just told you M2 receptor in the heart, they can decrease the heart rate. So, historically it was used. Nowadays, it's not used now that much. But it will be used for MCQ, that's why you have to learn it. Now, you know that cholinergic drugs can cause bronchoconstriction. So, we use methacholine to check whether the patient has a risk of asthma. So, it is used to diagnose bronchial hyperactivity. Bronchial hyperactivity or bronchial asthma. Now, when we discussed a topic called clinical trials, I told you we do something called animal studies before testing the drug on the humans. I told you there are certain diseases which are not at all seen in animals. Suppose you want to make a animal asthmatic, what we do? We give methacholine to that and induce bronchial asthma or bronchoconstriction, and then we try to give the drugs to see whether the bronchodilation occurs. So we use it in animal experiment also, that is methacholine. Otherwise, not much use nowadays. Another drug which is A old drug is carbachol. The problem with carbachol, it acts on M as well as N receptor. So the problem is non-specific action. So it is used to treat glaucoma only in some countries, carbachol. Then another important drug is bethanacol. The name is called bethanacol, and when you think of bethanacol, remember bethanacol for bathroom call or bowel call or bladder call. So it is used in bowel and bladder condition, and we all know that the concept. It is used in two important condition. What is that? Post-op paralytic ileus. Post-operative paralytic ileus, and one more. What is the one more post-op condition I told you? Urine retention. Post-op urine retention. One more bladder condition we use it is an atonic bladder. So that is the condition. Suppose a person is having asthma and he is in post-operative paralytic ileus. Can you use bethanacol? No. Asthmatic patient, cholinergic drugs should not be used. Please mark that point, because bethanacol is a cholinergic drug which can cause bronchoconstriction. Okay, yeah. So we know the story of acetylcholine, then bethanacol, A, B, C for carbachol and methacholine, and one more C. It's a drug called cevimeline. Cevimeline is a more M3 specific agonist, and it is used to treat mainly a syndrome called Sjogren's syndrome. Sjogren's syndrome. Okay. So these are the direct cholinergic drug. That means they activate the muscarinic nicotine receptor directly. Now the acetylcholine, it's not used because short-acting non-specific. Methacholine for heart and to diagnose asthma. Carbachol, glaucoma. Bethanacol, bathroom call. That is whenever there is post-operative paralytic ileus or post-operative urine retention or atonic bladder. Then cevimeline for Sjogren's, pilocarpine for Sjogren's, and pilocarpine eye drop for glaucoma. Aracholine, muscarine are not used therapeutically. Yeah. So these are all direct cholinergics. What are indirect cholinergics? Indirect cholinergics. So indirect cholinergics are also called by another name, anticholinesterase. So the meaning is they inhibit enzyme cholinesterase. So what happens if you inhibit that? The acetylcholine activity increases in the synapse, and this will act on the receptors M as well as N. So these drugs can act on both muscarinic receptor and nicotine receptor. So all the anticholinesterase drugs can act on both the receptors M and N. Now this anticholinesterase or indirectly acting drugs, we have two types in that. What are the two types, sir? Number one, the reversible ones. And number two, the irreversible ones. Sir, what do you mean by reversible? Suppose the cholinesterase enzyme, the drug will block that enzyme, after some time it will leave it. That is called reversible. What is irreversible, sir? There is an enzyme, the drug will bind, it will never leave it. Now you tell me which one is dangerous. Yes, if you are thinking irreversible, you are fine. Now, who can be used in therapy? Obviously reversible. So reversible anticholinergics are used in treatments. What are the drugs I need to know? In that, the first one we need to know is a drug by the name physostigmine. The name is physostigmine. Now physostigmine is called as a tertiary amine. It's a tertiary amine. Sir, what do you mean by that? A tertiary amine is made up like this, RNH2. Sir, what do you mean by that RNH2? It has the center N and then the H H and R group attached. So this is the RNS2, that is tertiary amine. In this, there is no ionized. This is non-ionized. You know the general pharmacology. Non-ionized drugs can easily cross the membrane. So these can easily cross membranes. Yes. So tertiary amines, they can easily cross the membrane. That means, are they able to cross the blood-brain barrier? Yes. So it can cross the blood-brain barrier. Even though if you give physostigmine as eye drop, it can also cross the corneal and conjunctival barrier. So that's the reason physostigmine is a tertiary amine. It can cross the blood-brain barrier and enter the brain. It can enter the brain. Okay, sir. So where to use it? Physostigmine. Physostigmine is the drug of choice for a poison called atropine poisoning. So atropine poison, it is also called as belladonna poisoning. It is also called as datura poisoning. So these are all the sources of atropine. So any of these in the exam, atropine poisoning, belladonna poisoning, datura poisoning, the drug of choice is physostigmine. Sir, why? Why? Because atropine also enters the brain and it blocks the muscle receptor. And we should give physostigmine, which also enters the brain and overcome the antagonism. That's the reason. Second, it is also used to treat glaucoma as eye drop. Why, sir? Yes, it can cross the corneal and conjunctival membrane and goes inside the eye and work. That's the reason physostigmine is used. So, drug of choice for atropine, and it is also used in glaucoma. Second important drug. They also start with the same name. You know physo, it also starts with the name pyridostigmine. Pyridostigmine. The first thing is, when I think of physo, I always confuse pyrido because both of them start with P and N with stigmine. Remember like this, physiology enters your brain. So physo enters your brain. If you remember that, another will not enter. So pyridostigmine and neostigmine. So we have pyridostigmine and neostigmine. These are called as quaternary amines. The name itself is telling you quaternary. Now quaternary amines, the same structure, they will have N, R, H and H. So they don't have one more side to attach the another H plus. So H plus ions are separate. So this will be ionized. So quaternary amines are a bit ionized. So you know that if they are ionized, they cannot cross the membrane. If they cannot cross the membrane, will they be able to enter the brain? No, they won't be able to enter the brain. So the question is, can I use them in managing atropine poisoning? No. Can I use them in managing the glaucoma? No. Then where do we use them? We use them in a condition where we can use them in periphery. So these two drugs, neostigmine and pyridostigmine, they are used in two conditions. So I know that when we block the cholinesterase, they increase the activity of acetylcholine. So acetylcholine activity is increased. How? They inhibit the enzyme cholinesterase. Acetylcholine is increased. So they can be used in two conditions. Number one, in the NM junction, what is the problem? And in M receptor, what is the problem? There we can use it. In NM junction, we use it, these drugs, in the management of cobra bite. So I told you, in cobra bite, the NM junction is blocked. How do you overcome that blockade? By increasing acetylcholine. How do you do that? By inhibiting the enzyme cholinesterase. Who will do that? Neostigmine, pyridostigmine. So the cobra bite, there will be muscle paralysis. So remember, the antidote for cobra bite is anti-snake venom. The antidote is anti-snake venom. Anti-snake venom. So along with that, we add neo or pyridostigmine. They are adjuvant drugs. They are not the antidote. Please keep that in your mind. They are not the antidotes. The antidote is anti-snake venom, obviously. Please keep that in your mind. Second, I told you during anesthesia, we would have relaxed the muscles. For relaxing the muscle, we use non-depolarizing muscle. Okay, I'll repeat here. Another concept I told you is in anesthesia, we relax all the muscles and we use certain drugs called D-tuberculin, pancuronium, atracurium. They relax the muscles. Now, once the OT is done, the operation is done, then we want the muscles to return to back. So that return can be made earlier or quicker by using these drugs. So that is called to reverse non-depolarizing skeletal muscle relaxants. So if you want to quickly come back from that, this is used neostigmine predostigmine. It is also used in the management of myasthenia gravis. It is also used in the management of myasthenia gravis. So what is the problem in myasthenia gravis? There is autoantibodies. These antibodies will destroy the NM receptors. Now when they destroy NM receptor, the muscle will not be able to contract properly. There will be weakness. But there are certain receptors which are not killed, which are not destroyed. So acetylcholine should act on them and work. So that's why we use neostigmine, predostigmine, which will increase the activity of acetylcholine, which acts on this receptor and muscle weakness is managed. So that is why we use them in myasthenia gravis. But when we are using these drugs in all these conditions, suppose I am using these drugs in a patient with myasthenia gravis, what is the adverse effect we expect? We are getting the muscle contraction back. But when we are using these drugs also act on muscular receptor and patient may have the dumbbell symptoms, diarrhea, urination, lacrimation, salivation. So patient may have adverse effect of muscarinic symptom. Muscarinic symptoms. Now the question is, how do you manage that muscarinic symptom? By using anti-muscarinic drugs. By using anti-muscarinic drugs. So I will give an example. Suppose a patient with myasthenia gravis, he is complaining, sir, I am salivating too much, I am having diarrhea. Then you use anti-muscle drug. Example is atropine. We'll discuss in the next video what are those. Now moving on to the M. Where do you take the advantage? Where do you want to stimulate them? Same thing what we have discussed for bethanacol. They are used for post-op 2 complication. What is that? That is paralytic ileus. Post-op paralytic ileus. And one more is called urine retention. And they are also used for atonic bladder. So one more funny question I will ask you. Suppose the patient, we gave these drugs for atonic bladder and start salivating. Can I use anti-muscular drug? No. If you give anti-muscular drug, they will block muscular receptor everywhere and you are not going to get any benefit. So only in these 3 conditions you are going to give anti-muscular drug because we want the action in NM, not in the muscarinic junction. Clear? Yes, so we are discussing the indirect acting ones, physostigmine, pyridostigmine, neostigmine. Let us come to the next one. So before going to that, they can ask in the exam which is longer acting. Pyridostigmine is longer acting compared to neostigmine. Yes, moving on to the third drug. The name of the drug is called edrophonium. Now edrophonium is one of the shorter acting drug. So because of the shorter acting, it is used in 2 conditions to diagnose myasthenia gravis. So it is used to diagnose myasthenia gravis because it's shorter acting. And the test, what we call it as, is tensilon test. Tensilon test. And also it is used to differentiate cholinergic versus myasthenic crisis. So we have discussed this edrophonium concept, myasthenia gravis, in a separate video, and there I have explained to you what is the difference between this crisis and how to diagnose myasthenia gravis. Now many a times if edrophonium is not available to diagnose myasthenia gravis, we can use neostigmine also, but since edrophonium is shorter acting, usually for diagnosis we use shorter acting drugs. Now, recently they had asked in the exam, tensilon test, what is the drug used? This is the question that appeared in the recent exam. Okay. So the name is edrophonium. Okay. Now moving on to the fourth drugs. Fourth group of drugs, very, very important. The name is called rivastigmine, rivastigmine, donepezil, then galantamine. Now these drugs are used in management of a condition called Alzheimer's disease. So it is used in Alzheimer's disease. Rivastigmine, donepezil, galantamine. Rivastigmine is also available as a patch. It can be applied as a patch. So the problem in Alzheimer's disease is there is decrease in acetylcholine activity and we want to increase it. There was an old drug called tacrin that is also used in Alzheimer's disease, but it was found to produce hepatotoxicity, and that's the reason it is now being banned. Tacrin is not used. Now, are there any other drug for Alzheimer's disease? Yes, they are not a cholinergic drug, but they have separate mechanism of action. What are those? The name is memantine. The name is memantine. Now, what is the mechanism of action? It's an NMDA antagonist. NMDA antagonist. Now, can you guess what type of receptor is NMDA? It's a glutamate type of receptor, excitatory. Now, how do you remember this? Memantine for memory time. So, Alzheimer's disease, there is decrease in memory. Memantine will increase it. Now, recently the question has been asked. Now, where do you use it? It is used for moderate to severe disease, not for mild cases. Moderate to severe disease, it is used. Now, should we use it single, that is mono, or should it be used a combination therapy with other drugs? It can be used monotherapy also, or it can be used combined. Another important point, how much is the dose it can be given? It is around 5 to 20 milligram per day. That is the dose which we can give for Alzheimer's disease treatment. That is called memantine. So it will come in medicine also. Let us understand here itself. Recently, a new drug has been approved for Alzheimer's disease, and the name is called ADU, map. So it is called aducanumab. So you can remember like this: Alzheimer's disease, you can beat it. So AD stands for Alzheimer's disease, you can beat it. Who can beat it? The drug can beat it. Now, this is a monoclonal antibody. Anything ending with MAB is a monoclonal antibody against what? Against a amyloid protein that is called beta amyloid. It is against beta amyloid, but the problem is it's a bit costlier because monoclonal antibody. So remember AD for Alzheimer's disease, and it targets beta amyloid. Now you can also remember like this: if you make it ulta, if you put this AD in the mirror, it looks like BA. So it targets beta amyloid. Okay, so these are the drugs for Alzheimer's disease. So the question keeps on coming for this part, Alzheimer's disease. Okay, so we have discussed the drugs which are indirect cholinergics, reversible one. Physostigmine, drug of choice for atropine, and it is used for glaucoma. Pirido and neo for neuromuscular junction, cobrabite. Then myasthenic gravis to reverse the D tuberculin. Then they can also be used in post-operative complications like paralytic ileus, urinary retention, and atonic bladder. Then we have edrophonium for diagnosing myasthenic gravis. Then we have rivastigmine, donepezil, and galantamine for Alzheimer's disease. Non-cholinergic mechanisms, memantine, it is used as NMDA antagonist. It is used for only moderate to severe disease. And ADA, so it is called aducanumab. So it targets beta amyloid. That's a new drug for Alzheimer's disease. So these are the important aspect I have to tell you. And one more question is, okay, it looks funny, but Rivastigmine, donepezil, galantamine, tacrine, do they cross blood-brain barrier? Obviously. Why? Because they have to treat Alzheimer's disease, that means they have to go to the brain. So that's the point. So once we understand these drugs, now we are left out with the last important one. What is the last important one? The last one are irreversible anticholinesterases. So irreversible anticholinesterase, these are not used in therapy because they are known to cause toxicity. So you have two important ones, the organophosphates and carbamates. So the organophosphate is malathion, parathion, then diflos, then we have diazinon, right? Now there were nerve gases used during war and they are called tabun, sarin, soman. So these are organophosphates. Now where do you use these organophosphates? Most of the organophosphates are used as insecticides or pesticides. So to kill the insect or pest we use it. Usually the farmers will using it. Carbamates, we have two important, one is carbaryl and propoxer. Okay. So we have discussed the OP and carbamate poisoning in a separate video in detail. I am just going to summarize the important points here. So in detail we have a separate video for that. So organophosphate and carbamate, they can be consumed by the farmer and come to the casualty. When it comes to the casualty, you will have the same problem of excessive cholinergic activation, dumbbells. So what is the drug of choice for OP poisoning? So let me conclude here. Drug of choice for OP poisoning is atropine. Along with that, you can add oximes. What is the drug of choice for carbamate poisoning? Again, it is atropine. But here, oximes are contraindicated. Okay, so the details of signs of atropinization, what are oximes, and all these things we have discussed in a separate video. Okay, and there is something called chronic OP poisoning. Now, what do you mean by chronic OP poisoning? Patient gets exposed to this OP slowly and for a very long period. The patient will have symptoms similar to multiple sclerosis. And is there any treatment for this? No treatment for this. So that is about the chronic OP poisoning. So in detail, if you want, we have a separate video for that and you can watch it. So guys, so that is about the first system, that is cholinergic, also called as parasympathetic system. So we started our video with making you understand why we should study ANS pharmacology. So I gave you some cases and I told you ANS, there is parasympathetic and sympathetic. Parasympathetic means relaxation, digestion, secretion, decrease in heart rate, bronchoconstriction, erection. Sympathetic means fight, flight, fright, anxiety, decrease in evacuation and decrease in secretion, increase in heart rate, increase in conduction, bronchodilation, ejaculation. The neurotransmitter in parasympathetic is acetylcholine. Receptors are M and N. Sympathetic, it is norelin, alpha and beta receptors. Then I told you the neurotransmission. Choline uptake is blocked by hemicholinum. Vesicle transporter is inhibited by vesamicol. You can inhibit the cholinesterase enzyme. They are called anticholinesterase. They are also called as indirect cholinergics. Acetylcholine is metabolized by the cholinesterase, but if you give it IV, it is metabolized by pseudocholinesterase. Coming to the drugs, we have direct and indirect drugs. Direct drugs, they directly activate the receptor. Acetylcholine are used therapeutically, methacholine for tachycardia, carbachol for glaucoma, methanacol for bowel and bladder, and then pilocarpine for the eye and Sjogren's syndrome, cevimeline for Sjogren's. Then we have indirect, reversible, irreversible. Reversible, we have physostigmine, drug of choice for atropine poisoning, as well as for glaucoma. Pirido and neostigmine for neuromuscular junction, that is myasthenia gravis, then cobra bite, and to reverse the DT procurement. They are also used in postoperative paralytic ileus urine retention. Edrophonium is the drug used to diagnose myasthenia gravis and to differentiate cholinergic and myasthenic crisis. Then we have rivastigmine, galantamine, donepezil used for Alzheimer's disease. The non-cholinergic mechanism, memantine NMD antagonist, and new drug is ADU canumab. Then after that, irreversible are the poisons OP and carbamate. For both the drug of choice is atropine. In OP poisoning, we use oximes, but in carbamate poisoning, oximes are not useful and they are contraindicated. There is something called chronic OP poisoning, and there is no treatment for that. And one more toxin they will ask you is botulinum toxin. Mechanism is decreases acetylcholine release, and it is used for the cosmetic purpose. Blepharospasm, strabismus, cervical muscle spasm. Onabotulinum toxin A is used for overactive bladder and migraine prophylaxis. So that is about the cholinergic system and the introduction of ANS. Thank you all.